Hello everyone. Sorry for the delay, just waiting for a few people to come in. Welcome to today's Connect and Learn webinar. I'd like to begin by acknowledging the traditional owners of the land on which we meet today and pay my respects to their elders past and present. I extend that respect to Aboriginal and Torres Strait Islander people listening today or in the future. My name is Rebecca and I'll be facilitating today's webinar, which is identifying and supporting clients with cognitive impairment, presented by Georgia Bolt. This webinar is a part of a Connect and Learn webinar series designed to support AOD clinicians throughout Victoria. We're going to make time for some, hopefully robust conversation at the end of the presentation, but our speaker, Georgia, will be presenting first off, and then we've allowed time at the end where you can ask questions directly to Georgia, or if you'd prefer to type them down, then I can ask them for you. We'll be recording the presentation, but not question time. And the recording will be made available on the Turning Point website later on. At the end of the presentation, we'd love it if you could take a few minutes to complete the evaluation survey, which will come up on a QR code on George's final slide. It'll also be sent to you via email later today. And George has kindly agreed to share a copy of her PowerPoint presentation. So sit back and enjoy the information she has to offer, and we'll send that to you later. Thank you, Georgia, so much for joining us. Georgia is a senior clinician, neuropsychologist working at Turning Point and Austin Health. She's also completing a PhD at Turning Point Eastern Health Clinical School and Monash University. Thank you so much, Georgia, for making the time.
Thanks, Beck. It's my pleasure to be here today to be speaking to you about how we can identify cognitive impairment and support our clients who might have cognitive impairment. This is a massive area, so I'm going to try to make it as brief as possible and really focus on some practical kind of clinical takeaways that we can implement in our practice. So, first things first, I guess, what are we talking about when we're talking about cognition, and why does it matter to this group? So, cognition really refers to a whole lot of different types of thinking skills. Most people will be most familiar with memory, but of course, there's lots of different things beyond memory, and that's all in that pyramid there down the bottom of the screen. We need the more fundamental skills at the bottom of the pyramid in order to then develop some of those more complex skills. So, we need to have basic alertness, arousal, attention, and concentration to take in information and remember it down the track. And likewise, we need to have reasonable executive functioning in order to sort of pull out that information from our memory store in an organized way. So, cognitive impairment arises when we get damage or disruption to any one of those sort of functioning of those networks, and that might be temporary or it might be permanent. So, this is relevant to our setting because we know that cognitive impairment is really common. There's estimates between 30 to 80% of people with substance use disorder can experience cognitive impairment at any one point in time, and that can adversely impact treatment engagement and retention. So, being aware of this is really in line with what the comorbidity guidelines recommend, as well as talking about how we can screen for it and recognise it, and how we can treat management as part of our core business. So, what can we do to recognise cognitive impairment? Often, when we receive referrals, the referrer has noticed that a client has reported cognitive difficulties, more likely memory difficulties. So, I think it's important to start there around subjective cognitive concerns. It's worth noting that subjective cognitive concerns, so what a client reports, does not always equal objective cognitive impairments. And in fact, the two often tend to dissociate. What the literature tells us is that people really aren't that great at identifying cognitive difficulties in themselves. So we know that those people who have higher self-reports of cognitive concerns, that's actually linked to higher affective symptoms, somatic symptoms, psychological distress, or substance use. And conversely, those people who have more marked cognitive impairment or a brain injury, they can sometimes lack insight or awareness, which is what we would call anosognosia, into those cognitive impairments. And so they might actually not have any impairments at all to report. They might tell you that they're fine, and that might be quite different to what you're observing clinically. So, worth holding this in mind that we can't just rely on what clients tell us. useful to listen to, but we need to think more broadly around what else could be going on. One other more objective way of possibly recognizing cognitive impairment is screening for it. So there was a systematic review done relatively recently now that looked at 14 different studies, exploring 10 different cognitive screens. And that was essentially looking at the diagnostic accuracy of cognitive screening tools in these populations. The recommendation from that review was that one particular screen, known as the MOCA or the Montreal Cognitive Assessment, was the most recommended for use. It shows the most consistent and adequate diagnostic classification. Worth noting, if you are wanting to administer the MOCA, that training and certification is required. Usually, we would be thinking that normal performance is anything of a 26 or above score. But worth keeping in mind too, there was more recently a study that sort of questioned the validity of the MOCA in people with substance use and co-occurring PTSD, which we know is a huge proportion of the people we see. And the recommendations from that paper was that perhaps we need to lower the cut score in this group and be thinking about cognitive impairment as anything less than 23. If you're going to be doing the MOCA, the recommendation is that you could do this on treatment entry as well as periodically throughout periods of treatment. Oversight from a clinician skilled in the area is usually recommended, and it is so important to be interpreting the findings that you get in context. A score by itself is relatively meaningless if we don't think about what was going on for the client at the time. And there's been a lot of research showing that heaps of different things, not just cognition, can impact that score. Also worth keeping in mind that there are other screening tools that you might come across. The MMSE is one that's commonly known, but it's not been recommended for use in this setting. There are two others that have been developed specifically for use in people with substance use disorder, the Bernie for alcohol-related impairments and the BEAT. Generally speaking, the MOCA was recommended over the Bernie from this systematic review. The BEAT does show initial promise, and that's more recently been validated in outpatients. So worth knowing about that one. It is a little bit longer than the MOCA, and that will also need appropriate training as well. I guess one thing to really emphasize if you are thinking about screening for cognitive impairment in your clients is that a cognitive screen is in no way diagnostic. All it will do is flag a client who might need further assessment, but it does not tell us what is going on for a client and if there's necessarily permanent cognitive impairment. It is so important to be interpreting those scores in context. So thinking about, was your client acutely intoxicated at the time? Were they withdrawing? Were they fully engaging or distracted? Were they in a state of psychological distress? And it's also been recommended that a clinician who's skilled in this area does provide oversight. So you could consider consulting with neuropsychology if you have questions about what you've done there too. I guess one other area, and this is where we can get so much rich information from, is what we're actually observing in clients. This can be so useful to help recognize cognitive impairments because there's actually a lot of clues that clients give us, and that can tell us what could be going on as well as what we could do to intervene. So, clues that your client might be struggling with attention or processing. This is going to be a client who's finding it really hard to maintain focus. They might be easily distracted either by things going on kind of in their own internal world or in the external environment. There might be repeated requests for information. So, this is the client that's saying, what was that? Sorry, can you tell me that again? They might lose the thread of conversations, including their own conversations, and sort of stop and say, oh, what was I saying? I can't remember what I was sort of saying. Or there might be delayed sort of processing. As I've already flagged, memory difficulties is the big one that people tend to report. But I think it's important to think beyond what people say and actually consider how the client presents those concerns and the quality of those concerns. This is because a client who will tell you they've got memory difficulties, but then proceed to give you a really contextualized, super detailed account of all of the little things that they've forgotten, probably don't have memory difficulties. So, this is a client who can tell you that they forgot to go to their mum's house yesterday and then they ended up going late. And when they got there, she asked them to go to the shops and they remembered to get the oranges, but not the apples. I mean, it's so detailed what they've forgotten, they're probably not struggling with a memory problem. They might be struggling with attention, but it's less likely memory. Conversely, if you've got a client who has absolutely no carryover of information from one session to the next with you, even if you provide a prompt, you're just sort of being met with a bit of a blank look. or they're repeating themselves and they're quite vague with the history that they're giving you, and they're really struggling to fit information into a meaningful timeline, that might be more indicative of somebody struggling with memory problems. Our client might be forgetting appointments or events, different medications. One thing we're often asked too is whether or not it's a motivational issue versus a memory issue. And I think there it's worth thinking about how pervasive the memory difficulties are. So if you've got a client who's forgetting just the appointments that maybe they don't necessarily want to go to, it's probably more likely a motivational issue. Whereas if it's quite pervasive across time and sort of context, it might give rise to more of a memory problem. One other presentation to be aware of, particularly in our clients who are quite heavy drinkers, are those who present with false memories, what we call confabulation. So they might be telling you stories or details that you actually know not to be true. And it's not necessarily that they're lying, it's actually that their memory system is trying to fill in the gaps around these islands that they've sort of forgotten. So worth looking out for that too. Finally, the big one that we tend to see in this group is difficulties with executive functioning. So, our executive skills are a little bit like the CEO of our brain. It is what allows us to plan and organize and set goals, stop ourselves from doing things that we might not want to be saying or doing. And so, if we have difficulty in any one or multiple of those areas, it can give rise to a whole host of different problems. You might have a client who is struggling to make their appointments on time. You might feel like they're needing a heap of support in order to engage. When they do engage, you might find that they're a bit more literal in how they interpret what you're talking about. They might kind of be a bit tangential, so you feel like you're starting to talk about one thing, and then next minute you're talking about a topic that's kind of loosely related and you're not quite sure how you got there. Um, Poor strategy implementation is something we see, particularly again in our alcohol clients, that dissociation between knowing and doing. They can tell you all of the things they need to do, but when it comes to actually actioning those things and implementing them, they can find it really tricky. Poor emotional regulation can also be linked to executive dysfunction. So that's the client who'll kind of go from 0 to 100 really quickly, or might be a bit more disinhibited with you. So, when it comes to recognizing cognitive impairment, I guess the key thing is to be using multiple sources of information, not just relying on one thing. So, we don't just want to be looking at what a client is saying to us. We want to think about the quality of those concerns that they're reporting, the functional impact of those concerns, as well as the onset and the course. So, when did these difficulties start? Are they getting worse? Are they fluctuating? If they are fluctuating, what are they fluctuating in accord with? Or have they improved over time? You might consider doing a cognitive screen. If you're going to do one, the mocker or the beat are probably the way to go. But do make sure that you receive appropriate training, that you're really paying attention to the context in which you're doing those assessments, and you're getting sort of consultation as needed. Perhaps the opportunity to get the most rich information comes from our observations of what clients are doing and how a client presents. So, really think about the nature and the pervasiveness of a client's presentation, not just within sessions, but across sessions, because that can allow us to better understand what could be going on and what different strategies we might need to put in place. So, we've clearly identified that there is a large proportion of people who experience cognitive impairment in people who use substances. I guess the question is why? Short answer to that question is it's often lots of things. So, when we look at all of the research that has come out of our clinic, multiple contributing etiologies has been the common opinion as to what could be going on for people. So, I think it's worth holding that in mind. It's usually more than one thing. People are often wondering about the impact of substance use on long-term cognitive impairment. And I've popped up some different literature in the slides there, which I won't read out in detail. You'll have access to this to look through in your own time. I guess the key takeaway to think about is that all substances are likely going to have an acute effect on cognition. We wouldn't be surprised about that. The bigger question is whether or not it gives rise to longer term cognitive impairment and or brain injury. And there has been suggestion that there's really scope for cognitive recovery with abstinence for the most part, with long-term cognitive impairments with abstinence debated. Worth keeping in mind, there's a lot of methodological limitations when it comes to this literature. We want to be thinking about issues around, single substance use versus polysubstance use, primary substance of concern, duration of abstinence, how we're assessing cognitive impairment, and whether we're thinking about a statistical versus clinical significance. So keep that in mind if you're looking at the literature, it's really messy. Perhaps the strongest, most consistent evidence that we have is for more persisting cognitive impairments to arise in individuals who have been drinking in excess of recommended guidelines. So that's no more than 4 standard drinks in a single session, no more than 10 in a week. And of course, that's going to be a little bit lower for our females and for our older clients. We also want to be thinking about the host of things, medical, psychiatric conditions that are associated with substance use, because that can also indirectly impact cognition as well. So things like substance-induced psychosis, metabolic disturbance, nutritional dysfunction, trauma, disturbed sleep, and they're all opportunities for us to intervene and support brain health and cognition as well. So, when it comes to what we can do if we're thinking about the impact of substance use on the brain, I think a really empowering message that we can give to clients is for the most part, we do see cognitive difficulties improve, if not resolve, with periods of abstinence. That's, of course, going to vary depending on the client and their use, but for the most part, that's what we can sort of suggest. Existing evidence does emphasize that chronic heavy alcohol use might be more likely to contribute to long term impairment with females more vulnerable, as well as people at either end of that kind of age spectrum. So, we would really be recommending people engage in AOD treatment and prioritize abstinence where possible. And then, if there is a diagnostic question, we would recommend waiting usually around 6 weeks before addressing that question. Of course, there's going to be variability depending on the clients that we're working with. Supporting nutrition is a big one. We really want to be prioritizing thiamine for people, especially if your client has an alcohol history. And worth keeping in mind that if you have a client who is frankly confused and or having difficulties with their balance or with their vision and they have an alcohol history, do consider an admission to hospital because they might actually be at risk for Wernicke-Korsakoff syndrome, which could be treated with high-dose IV thiamine. Mental health support via a mental health practitioner might be worthwhile. If you've got a client who's struggling with sleep, there's good evidence that CBTI is an effective method to address insomnia. So if you're looking for providers, sleepcentral.org does have a directory there. Sometimes referring on to the GP to get some comprehensive blood work done can help to rule out other underlying contributors that might be impacting cognition. And really important that we're alert to polypharmacy and sedative load in some of our clients. That's a potentially modifiable sort of risk factor that we can look at. So they might benefit from medication review as well if there are concerns. Now, one question we're often asked is whether or not their client has an acquired brain injury. And I guess without going too much into the details of what we look for, we will be running a workshop on this later in the year for those who are interested. I really want to encourage people to avoid using this label if it hasn't been formally diagnosed because labels stick and there's already so much stigma in this area. We don't want to be adding another label where it might not necessarily be indicated. Clients will often report, having a knock to the head, being assaulted, being in car accidents, overdoses, etc., etc. But it's worth knowing that a knock to the head is not the same as an acquired or traumatic brain injury, and likewise, an overdose does not equal a hypoxic ischemic brain injury. There are different indicators of injury severity that we look for. Things like the duration of loss of consciousness, usually being more than 30 minutes if we're thinking about a moderate or severe injury. And so there's a lot of value that comes from actually requesting medical records and looking at what was going on for the client if this is something that they're reporting rather than just sort of using this label inappropriately. Also worth holding in mind that not all cognitive impairment that you see is going to be a brain injury or is going to be permanent. There are multiple factors that will have an interacting and cumulative effect on the brain across the life course. And so, really, prioritizing addressing some of these potentially modifiable risk factors can actually have great benefit for clients. So, think about their substance use, their emotional distress, sedating medications, as well as general kind of medical issues that could be targeted, because that might actually give rise to a lot of benefit for clients. One other thing to be aware of is that cognitive difficulties might actually predate substance use. So we know that there's really high base rates of neurodivergence in the AOD setting. We see the prevalence rates of ADHD being 3 times that in people who use substances relative to those in the general population. Similarly, there are higher rates of autism in people who use substances. We see almost half of people with intellectual disability using substances and 20% with specific learning disability using substances. So it's really common and it's something that we need to sort of be alert to. And given that, the Australian guidelines, as well as the international consensus statement, have recommended that ADHD is actually screened for in all patients within the substance use setting. So if you are getting a history of long-standing difficulties, do consider screening. The ASRS-5 is one screen that you can do. It's quite quick, it's 6 items, and it's available there at that website that I popped on the screen. Also worth keeping in mind that there is a strong co-occurrence with ADHD and autism. So although it's not technically recommended for use as yet in this substance use disorder setting, failure to screen for autism might actually contribute to worsening of symptoms. So you could also consider screening for that as well if you're getting a bit of a clinical history and if you're noticing symptoms clinically as well. So the RITFO is one screen you could do, that's the RADS 14, and again, I've popped that up there. Keep in mind, a screen is just a screen, it is not a diagnosis. So if you've got clients who are endorsing elevated symptoms here, again, it might be indication that you need to refer on. And if you're looking for people who specialise in this area, there are directories available via the ADPA website and the Lower PAC website who have a list of neuroaffirming psychologists and psychiatrists. So really important that we are considering a neurodevelopmental and lifespan perspective in this group because the difficulties with cognition might actually predate substance use. And this is particularly important for our young clients under 25 because they might actually be eligible for multidisciplinary assessment, diagnosis and treatment under Medicare. So we obviously have talked about the prevalence of cognition and cognitive impairments. How can we actually adapt our practice to support these clients? So the strongest evidence that we have is for around implementing compensatory strategies. So by changing the way that information is delivered and the environment within which clients are, that can actually help to support their brain and cognition. Really important, though, that we normalize strategy use. We all benefit from strategies every day, whether or not we've got difficulties with cognitive impairment. And I think it's important that clients know that so they don't feel that there's something wrong with them, and that can sometimes be a barrier to engagement. It's also essential that strategies are tailored to your client. So just because something has worked for one person does not mean it's going to necessarily be rolled out and work for somebody else. There's no kind of one size fits all approach. It's much more around thinking about who your client is, their preferences, what they do well and what their strengths are. What have they tried before? What worked, what didn't work, and what are their goals? Because if we can link strategies to clients' goals, that gives us really good buy-in to actually keep engagement longer term. So if you have a client who is struggling with attention, there's a few things I guess you might want to think about. The first is going to be thinking about how you can actually reduce distractions. And those distractions might be in the external environment, but it also might be in the client's internal world as well. So obviously things like background noise is going to be a big factor to think about. But there's also other things that might not be as obvious. So things like how many people are you bringing into the room? Is that going to be really overwhelming? And can we limit the amount of people? Recognizing the high rates of trauma and neurodivergence in this group, you also want to be thinking about the positioning in the room. So sometimes for clients who are neurodivergent, sitting face to face is actually going to draw more on attentional resources because they're having to think about things like the eye contact and the social pragmatics that are involved in that interaction. And so perhaps putting yourself beside a client might actually reduce that attentional load. Likewise, a client who is quite hypervigilant might struggle if they've got their back to a door. So explore that with them and explore if they're going to be more comfortable having a door slightly ajar or fully closed. Think about removing visual clutter off the desk, off the walls. Think about if the client has a mobile phone on them. If they do, can we put it on silent? Can we turn it off? And also explore what else is going on for the client at the time, because if they've got lots of things planned or if they're late to get somewhere in the afternoon, they're not going to be kind of present with you. So try to really pay attention to what else is going on for them. Think about the time of day that your sessions are and how long those sessions might be. Usually we say mornings are best, but again, that's going to depend on your client, their sleep-wake schedules, their substance consumption, etc. Sometimes for people with cognitive impairment, we might want to make sessions a bit shorter, and we might kind of want to cluster sessions and do a few more at the beginning and then spread things out over time. There's good evidence for what's known as the Pomodoro method. And so you could even, have a bit of a printout of this and provide this to your clients because it gives a nice visual. This is essentially where you sort of sit for 25 minutes and then you take a 5-minute break. And you do that in some chunks, and that's been shown to promote efficiency and mood. Of course, we want to think about how we can support sensory preferences as well and opportunities for stimming. So, thinking about the lighting and the sound in the area, think about movement too. So, does your client need to sort of get up and move around? Do you need to be doing a walking session, maybe having a spinning chair so they can move, or maybe having some different fidget toys that they could use? And there's been evidence to show the value of doing some of these things for people with ADHD. Of course, we want to have a trauma-informed approach that's going to optimize people's attention and their window of tolerance. There's evidence about the value of exercise, movement, as well as stillness and grounding on brain health in general. So, spending 1 hour outside in nature has actually been shown to reduce activity in a part of the brain called the amygdala, and that is what is involved in our fight flight response. So, by reducing the anxiety and cortisol there, we actually see improved cognition, mental, and physical health. So think about how we can get our clients outside, how we can encourage them to do exercise, and just spend some time in nature. The teach back strategy is another really good way to check in with clients as to what they've actually understood. You don't want to make this feel like they're being tested, but sort of building this into a conversation to say, hey, I know we've talked about heaps of different things today. I want to make sure I've been clear. What have you taken away from today? And then that gives you an opportunity to hear if the client's actually been taking it in. And if they need it, you can always repeat yourself or provide clarification as needed. When it comes to supporting memory, there are so many different things we could do, so many different apps and tools and reminders, etc., etc. So I think it's most helpful to think about the general principles of why we're doing what we're doing. So the key things to keep in mind is that the more we work with information, the more we're going to remember it. So we want to make our learning as active as possible. We also know that recognition is easier than free recall. So that means if we provide prompts or cues, that's going to be able to support a client's memory better than just asking them to freely recall things off the top of their head. We also know that forgetting is adaptive. So, natural forgetting is actually a part of neuroplasticity. It's a part of a healthy memory system, and it allows us to focus on what's really important, what's really salient. And I think this is important to explain to our clients, particularly clients who might have a degree of anxiety around memory failures, because it can actually kind of normalize that process and let them know, hey, this is a normal part of brain health. So, holding these general memory principles in mind, there's a few different things we can do. We might want to be encouraging note taking, calendar or diary use of prompts or reminders. That could be on the phone, on Apple Calendar, Google Calendar, whatever your client's preference is. So, thinking about, is your client really techie? In which case, go for things on the phone. Or otherwise, if they don't really like technology so much, maybe it's about getting them to use a handwritten diary or a big calendar on the wall. So, really work with your client around what works for them. Note taking is one of those things where usually using a notebook is going to be better than sort of tearing out random bits of paper that will get lost. And thinking about whether or not you need to build in breaks in session for your clients to be writing notes, or if it's something you could do together. Because usually the process of writing notes and listening to someone actually relies quite heavily on our attentional system. So we want to try to reduce the load there. One challenge that people sometimes talk about with these kind of tools is they might have a notebook or they might have a calendar and they lose it or they forget to bring it. And I think this is the value of building out what we call a memory station. So, encouraging our clients to create a memory station in their homes, putting that in a place that they would frequently walk past, so maybe near the front door, And that is the place where everything that's important goes: their phone, their keys, their diary, their medicines, a calendar on the wall. And the more they get into the habit of when they walk in the door, everything goes down there, and when they leave, they grab everything from the memory station, the better that's going to support their memory. We want to be encouraging routine and consistency, not just within our sessions, but in our clients' life more generally. And of course, to make learning active, we want to be doing demonstrations and role plays rather than just sort of sitting and talking through the processes as well. We want to think about how we can make information accessible to our clients. So, really simplifying down the information that we use and pacing ourselves, building in breaks, opportunities for information to get consolidated and to kind of sink in. If you're providing handouts, think about if the handouts are actually using easy read language. And if you're not sure, Scope do offer a consultation service around how to make that your language more accessible. But there's also easy read resources available on the Alcohol and Drug Foundation website as well. We want to think about, again, presenting information in a multimodal way. So, how can we do it in a verbal way and a visual way? Can we incorporate diagrams, pictures, draw things on the whiteboard, handouts for people to take away? Because that's going to give optimal benefit for memory. We want to use relatable examples. Get the client to think about when they've experienced this, what this might be relatable to, because that again makes the learning process more active and it's going to support memory later on. Finally, we want to be thinking about things like hearing, vision, disability, and cultural and linguistic factors. So, if you've got a client who's struggling with hearing, think about the National Relay Service to support them over the phone. If you've got a client who has a different sort of cultural background, think about whether or not they need an interpreter. There is an interpreter service available. And likewise, think about different apps that might be available for disability. So the Sunny app is one that's quite good um, to help recognise violence and abuse and to get supports for our women who might have a co-occurring disability. And of course, when it comes to supporting executive function, we want to be thinking about setting a goal and then breaking that goal down, possibly even popping it onto a goal ladder to make it really concrete and tangible for clients. When we are helping clients to prioritize information, we want to be linking that to what's important to them, what their values are. And so I've popped a picture there of some values cards that might even be a good activity to do together because that again helps with buy-in and sustaining engagement over time. The Stop Think Act is a really good strategy that clients can use, and you could even sort of cut that out and give that to clients as a bit of a card for them to remind themselves that when they're kind of going to do something or say something without thinking, just take a moment to stop, count to 10, think about if that is in line with their goals that you've already discussed, and then act. And finally, if you've got a client who you're struggling with different sort of behavioural challenges, behaviours of concern, think about implementing a behaviour monitoring chart and noting down what is actually happening, but also what is happening before that behaviour, because oftentimes there are clear triggers. And if we can mitigate some of those triggers and reduce the likelihood of those triggers, behaviour tends to settle. So, this is really just to sort of highlight that although some of these strategies might seem quite simple on the surface, there's a lot of value that can come for clients. So, there was a piloted adapted resi rehab program done up in New South Wales a couple of years ago, where they had 67 residents, 33 of whom had cognitive impairment. And by implementing some of these strategies that I've popped up on the screen, they actually found that treatment completion was 5 times higher. So it doesn't take a lot, but it does take consistency, and we do need to be making it personalized to our clients. You might have some clients where you're feeling like they actually need to be referred on for further assessment. So, neuropsychologists, we explore cognition and brain behavior relationships to help inform diagnosis and guide management. So, we don't do brain scans, we do a whole lot of paper and pencil kind of tasks, and we use those things. They've got normative data. We draw on our clinical observations, which is some of what I've talked to you about today, and we bring that all together with the client's history and knowledge of what's going on in the brain. And that can kind of help to inform diagnosis and management. We do need to be careful about when we repeat neuropsych assessments because there is the potential for practice effects to occur. So, with that in mind, we're quite considered with if and when neuropsychology might be indicated. So, I've popped up on the screen a few questions, I guess, to be thinking about if you are wanting to refer on. The first thing's going to be, well, what is the referral issue? Are you seeking a diagnosis? Are you wanting support with management? Because depending on what you're looking for, that's going to guide the timing or the appropriateness of neuropsychology. If you're querying whether or not your client has an acquired brain injury, you actually want to be thinking about, well, is there a sufficient mechanism of injury? So we will be wanting to encourage accessing medical records and going from there. Alongside that, we also want to be thinking about whether or not you're noticing pervasive cognitive and functional impairments. So, not just relying on what the client's telling us, but are we actually seeing pervasive impairments that have persisted despite addressing all of these other factors? And then finally, we want to be thinking about if it's the right time. So, can the client meaningfully engage with everything else that's going on? Is this a priority for them? And also, have those modifiable cognitive risk factors that I've spoken about been addressed? Because that's always a really good target to start off with. If you're looking for other supports, we do have the practice guidelines available on the Turning Point website, and our clinic offers a comprehensive care planning and formulation telephone service. So if you've got a general inquiry, you can call us anytime. Happy to have a chat. If you want to discuss a specific client, pop a referral through. Our referral forms are available on our website. So if you just Google neuropsychology Turning Point, as I've done there, it should be the first thing that comes up. So, to sum up, really important that we're alert to cognitive impairment, use multiple sources to sort of recognize what's going on. So, don't just rely on what a client says, think about using screening tools, but if you're going to do that, think about the context and make sure you're trained and use your clinical observations. Consider the possible contributors to guide management. There's often lots of things that go on for people. Think about things across a lifespan because it might actually predate substance use, and really focus on addressing those modifiable cognitive risk factors first of all. And finally, think about how you can adapt your practice to support your client. There's a lot of benefit that can come from popping in place some of these strategies that we've talked about. And if you are thinking about referral to neuropsychology, do think about the appropriateness and the timing of that referral. So that was everything I wanted to go through today. Were there any sort of questions or discussion points?